pandemic started from Wuhan. It started from Wuhan, China, back in December of 2019, and it spread out globally. It's basically the coronavirus is part of the SARS-CoV-2 virus, which first started in the Wuhan, China, like we said, in December of 2019, and it spread globally. The COVID family or coronavirus family are they usually cause respiratory and GI symptoms and illnesses in both the humans and animals. And these viruses usually presents with mild cold symptoms like flu symptoms back in the 2002, as well as in 2012, and it was epidemic at the time. It was known as SARS for severe acute respiratory syndrome, as well as MERS, which is Middle East respiratory syndrome on the Arabian Peninsula at that time. These viruses, usually they can become severe life-threatening illnesses, or they can cause severe life-threatening illnesses. From the name, the corona, which is in Latin meaning the crown, the jewel crown, and is known or given the name from its natural look or appearance, which is the spikes, the spiky proteins that it has. The structure itself is coded by RNA virus with the spiky protein, which helps the virus binds and invade and infect the natural human cells. So these spiky protein are also helpful in developing vaccines, which are the main source of management, or the main treatment that we're using to prevent or also to help reduce the pandemic. So next slide. The next slide is basically about the vaccines candidates, the ones currently in clinical trials, as well the ones approved worldwide. We have about 222 vaccine candidates. 771 vaccines are currently in trials, and 78 countries with vaccine trials. I'm sorry about the loud noise in the background. 56 vaccines are currently in phase 1 trial, and 71 vaccines are in phase 2 trials. 85 vaccines are in phase 3, and 40 vaccines are currently approved worldwide. So in the US, we have about 4 vaccines that's currently available and approved by the FDA. And according to their mechanism of actions, one works as a mRNA vaccine, which is Pfizer's and Moderna, and the adjuvant recombinant protein vaccines, which is Novavax, and the adenovirus vector vaccines, which is Johnson & Johnson by Janssen. I'll talk briefly about the mRNA vaccine, which are Pfizer, for example, which is FDA approved to be used on any children from the age of 12 years and older, as well as an emergency use authorization for children from 6 months to the 11 years of age. The dosages, it depends of if you're immunocompromised individual, we give them up to 3 doses regarding the Pfizer, and sometimes up to 5 doses if they're in adults and like an elderly individual, immunocompromised individual. And usually it's 3 weeks to 4 weeks apart between the first dose and second dose. So the Moderna as well is FDA approved mRNA vaccine, and also could be given from 18 years and older to elderlies as well, and immunocompromised individuals. And it also has emergency use authorization for children 6 months to 17 years of age. And we can give them up to 5 doses for immunocompromised and elderly individuals. And also it has about 4 weeks between doses from the first dose to the second dose. And then we also have the adjuvant recombinant protein vaccine, which is Novax. It's a subunit protein, subunit COVID vaccine, and is developed by the Collaboration for Epidemic Preparedness Innovations, the CEBI. And it's a small biotechnology company in Maryland that faced several problems at first with manufacturing, and then after 2 years of the development, or of their development, the vaccine has finally earned the clearance by the FDA. And the age group is from 18 years and above. Administration is 2 doses. It used to be for 1 dose, but now is considered for a second dose to be given. 0.5 milliliter IM injection, and its interval is 3 to 4 weeks. Adenoviral vector vaccine is Johnson & Johnson, which is by Janssen, and it's a viral vector vaccine based on human adenovirus that has been modified. The gene has been modified for making the spike protein of the SARS-CoV-2 virus, and is developed by Janssen Vaccine in Leiden, Netherlands, and the American Johnson & Johnson. The age group is 18 years of age and older, and administration is a single dose of vaccine of 0.5 milliliters, and it's IM injection. Booster can be received 8 weeks. It's the only one that's it has a 8 weeks interval after the primary dose, either or any other mRNA vaccine. It doesn't have to be Johnson & Johnson, it could be Moderna or Pfizer as well. So just a brief note, mRNA COVID-19 vaccines are preferred over the vaccine due to mRNA vaccine, primary, series, and booster vaccines. So this is according to the CDC guideline, all the dosages and the vaccines available in the US, and how many doses are given and to which age group is indicated for. I just added it briefly. And these are the references we had used. Thank you, everyone. And again, sorry for the delay and the noise. I wasn't prepared for it. I just got home.
Thank you very much, Dr. Dua, for giving an insight about the COVID infection and different kinds of COVID vaccines available. So our next presentation would be by Dr. Anna, who's going to present the different about the contraindications of the COVID vaccine.
Okay. Hello, everyone. You see my screen?
Yes.
Let's go. I'm gonna talk about contraindication and precaution to COVID vaccine. Contraindication as general history of severe allergic reaction, anaphylaxis after a previous dose or a component of COVID-19 vaccine. For as recommendation, we do not vaccinate with the same time of COVID vaccine. we have like to alternate to another type like mRNA, Novax, Janssen COVID vaccine. History of non-diagnosed allergic to component of COVID vaccine. We recommend that simply as do not vaccinate with COVID vaccine that contain that component. For Janssen vaccine, thrombotic thrombocytopenia syndrome following recipient or previous Janssen vaccine or other COVID vaccine not currently authorized in United States, like AstraZeneca, we do not vaccinate with Janssen vaccine. Vaccine not recommended at all or with super precaution. If the patient have received Johnson COVID vaccine and has a history of an episode of immune-mediated syndrome characterized by thrombocytosis and thrombocytopenia, such as spontaneous or classic heparin-induced thrombocytopenia, or a history of Guillain-Barré syndrome within 6 weeks after recipient of Janssen vaccine. So those people should receive booster dose using an mRNA COVID vaccine. Use with precaution. In those people, the benefit of vaccination outweighs the risk of most people, and the condition if a history of an immediate allergic reaction to any vaccine other than COVID vaccine or any injectable therapy, like intramuscular, intravenous, or subcutaneous vaccine therapy, in excluding from that subcutaneous immunotherapy for allergies, like allergy shot. Another category, people with history of non-severe but immediate, less than 4 hours or within 4 hour allergic reaction after a dose of one type of COVID vaccine and have precaution to the same type of COVID vaccine. The third category, people with allergy-related contraindication to one type of COVID vaccine have contraindication or precaution to other type of COVID vaccine. As we said, in those people, the benefit outweighs the risk. We continue in precaution. If the patient have moderate or severe acute illness with or without fever, we recommend defer vaccination until the illness has improved. History of multisystem inflammatory syndrome. We recommend vaccination outweighs the risk if clinical recovery has been achieved, including return to normal cardiac function, and has been at least 90 days after the diagnosis of multisystem inflammatory syndrome. If there is history of myocarditis or pericarditis after a dose of mRNA or Novax, we recommend that subsequent dose of any COVID vaccine should be generally be avoided. Type of reaction, immediate allergic reaction, defined as any hypersensitivity related sign or symptom such as urticaria, angioedema, respiratory distress, or anaphylaxis that occur within 4 hours following administration, like immediate reaction. Severe allergic reaction, possible anaphylaxis, or progressive life-threatening reaction that typically include urticaria, but also other systemic symptoms such as wheeze, difficulty breathing, or low blood pressure. Any angioedema affecting the airway, tongue, uvula, or larynx. Diffuse rash, which also involve mucosal surface, as Stevens-Johnson syndrome. The third type is non-severe allergic reaction, is urticaria beyond the injection site. Angioedema involving lips, facial skin, or skin in other location. As a note, any angioedema affects the airway, tongue, uvula, or larynx is considered a severe allergic reaction. Observation period following vaccination to monitor for allergic reaction. CDC recommend that following observation period after COVID vaccine, 30 minutes for people with contraindication to one type of COVID vaccine who are receiving another type that has been deemed a precaution. For example, people with contraindication to messenger RNA COVID vaccine should receive Novavax or Janssen vaccine. History of non-severe but immediate within 4-hour allergic reaction after a previous dose of COVID vaccine. History of an immediate allergic reaction of any severity to non-COVID vaccine or injectable therapy. And history of anaphylaxis due to any cause. Those people will wait for 30 minutes and 15 minutes to all other people. And that end my slide. Thank you so much.
Thank you, Dr. Amna, for
Dr. Nader,
providing
do you
us.
want to comment now or after each slide or at the general at the end?
Maybe at the end.
Okay. Sure.
Yeah. Thank you, Dr. Amna. So since we got to know about the contraindications of COVID vaccine, let's move on to our next topic, which is side effects of different COVID vaccines, which will be presented by Dr. Khulud.
Hello, everybody. Could you hear me? Hello?
Yes.
Yeah, we can hear you.
Okay, thank you. Let me share my screen now. Could you see my screen now?
Yes.
Yeah.
Yes. Yes, hello everybody, and good evening. I'm going to present COVID vaccine side effects, which prepared with me and Dr. Khulud Ahmed, and Dr. Sulafa Mahmoud, and Dr. Arid Al-Shafi. I'm going to start with the general side effects of COVID vaccine in general. I will not talk specifically as like per vaccine. I will talk as a general idea, and then I will go to specific side effects according to the systems. So let me start with common reported symptoms after the vaccination. So the common reported symptoms are soreness and fatigue and myalgia. Also, people can get headache and chills, fever, and joint pain and nausea and muscle spasm. Also, they reported sweating and dizziness and flushing and feeling of like a relief and pain, like a brain fogging, I mean. So people also can get anorexia and localized swelling as well. And they had also reported decreased sleep quality and itching, tingling. Also, they have a GI effect like diarrhea. Also, they're getting nasal stuffiness and flu-like symptoms as general. And they are also getting palpitation. In some cases, like not very huge numbers of cases, they get anaphylaxis, which was life-threatening allergic reaction that have been reported along with other adverse events of Pfizer. This one, I just like get the point of that to the vaccine. That's one related to vaccine adverse event reporting system, and it's rarely occur after vaccination. With the onset typically within the minutes to hours. Okay. Then we have here the most common injection sites reaction and delayed large local reactions. This almost arising from all vaccine types. That's where redness and erythema in the site of injection, I mean, and some swelling and itching and urticaria rash on the neck. And also they had it in upper limbs and the trunk as well. They will get also like morbilliform eruptions and like some pityriasis rosea And this also by the mean of the idea of swelling and burning and so forth. So also they had most common cutaneous reaction that's occur typically like in women, they notice that, and in the middle-aged people after the first dose of the vaccine, with the onset range from 1 to 21 days after vaccination. In addition, cutaneous reactions were generally self-limiting, that does not need any medical intervention, no need for any treatment. It will go by itself, or needed a little or no therapeutic intervention. That were not regarded as a barrier to injecting a second dose. So if we had these general reactions, that will not let us to just like not giving the second dose. That's safe and we can continue with the second dose. Also, we have a general idea also about the side effects of the vaccine in the pregnant women. So they reported that there were no significant differences in the rates of the side effects according to whether the vaccine was administered during the first or second or third trimester of the pregnancy. So except for local pain and swelling, which was significantly less common after the first dose when administered during the third trimester, and some uterine contractions, not that much, which were significantly more common after the second dose when administered during the third trimester. By the way, the rates of obstetric complications, including uterine contractions and vaginal bleeding or pre-labor rupture of membranes, were very low following the vaccination. So it's totally safe with the pregnancy and no contraindication with pregnancy. Okay, sorry for that. It's like two parts. I have to merge it together later. Let me go with the other one. Okay. Sorry. I want to go here. Okay. Okay, that was the idea about the general side effects and the general population and the pregnancy. Now I want to just give an idea about specific symptoms or side effects according to the systems. So we got some cases of thrombosis associated with thrombocytopenia have occurred following the vaccination with AstraZeneca COVID-19 vaccine. This is specifically reported, so I just highlighted. And the current knowledge on the epidemiologic and pathogenic mechanism of this syndrome, named vaccine-associated immune thrombosis and thrombocytopenia. The relationship between myocarditis and pericarditis after COVID-19 vaccination has led to the belief that the vaccine may act as a trigger for these cardiologic complications. Myocarditis and pericarditis after COVID-19 vaccine have been reported more in young adults, male, and are most likely to occur after a second dose of mRNA, messenger RNA vaccine. Okay, a case of a new onset renal limited ANCA-associated vasculitis was also reported. Here we have medical conditions have been reported in temporal association with the receiving of COVID vaccine as general. Then also we talk about the thrombosis with thrombocytopenia syndrome, which was a rare syndrome characterized by venous or arterial thrombosis and thrombocytopenia. And also we can get Guillain-Barré syndrome and autoimmune neurologic disorder characterized by ascending weakness and paralysis have been reported after Johnson COVID-19 vaccination. Also, we have one myocarditis and cardiac inflammation reported after Pfizer vaccination or Moderna vaccination, particularly after the second dose. These were viewed together and will thereafter be referred to mRNA COVID-19 vaccination. Okay, we have here the most frequent neurological side effects of SARS-CoV-2 vaccines are headache and Guillain-Barré, as I said, and venous sinus thrombosis and transverse myelitis. Other neurological side effects occur in a much lower frequency. Neurological side effects occur with any other approved vaccines, but VST particularly occurs after vaccination with vector-based vaccine. We have also cases of herpes zoster, which was reported following vaccination too, in patients with autoimmune inflammatory rheumatic diseases. That was reported, as I mentioned. So here the objective of this report is to raise awareness of reactivation of herpes zoster following the vaccination, PNT162b2 messenger RNA vaccination in patients with AI2RD. Okay, that's all, and this is our reference. I'm done with it. If any question or any.
Thank you, Dr. Khulud. I think Dr. Nader already informed that he's gonna comment at the end of the meeting. Yeah, thank you for a very good presentation and giving us an insight about the side effects of COVID vaccines. So let's move on to our next topic, which is overall efficacy of COVID-19 vaccines, which will be presented by Dr. Shaja. Go ahead.
Good evening. My name is Shaza Mohammed. I'm going today to talk about the overall efficacy of COVID-19 vaccine, which is prepared by me, Dr. Shaza, and Dr. Jamila. At first, although COVID-19 vaccine are an important strategy for preventing COVID-19 sickness, none of them are 100% effective. And since December 14, 2020, more than 25 million people have received their recommended vaccine. And after 1 month from the initial immunization, the level of protection from systemic COVID-19 started to decline. In contrast, a recent study by a researcher at Penn State College of Medicine found that immunity against severe COVID-19 lasts approximately 6 months. The researcher compared data from 7 million people who had received vaccination and those who have not. The latter group received doses of COVID-19 vaccination from Pfizer, Moderna, and Johnson & Johnson. And the researcher looked at a team-peer review article published between December 19 and November 21 before the development of Omicron variety that dominated the most recent pandemic wave in US. In systematic review and meta-analysis. And the results show that immunity against COVID-19 infection reduced following complete vaccination, going from 83% after the first month to 22% after 5 or more months. And the result demonstrated that those who received the Moderna vaccine enjoyed the highest level of protection. And according to the senior author, Dr. Catherine Pauls, assistant professor in the Department of Medicine, she said it's encouraging to observe that those vaccinating against COVID-19 retain high protection against hospitalization and mortality over time, even as effective against even as the effectiveness against infection is waned. And however, those who received the Johnson & Johnson vaccine have the lesser protection, 70% against the severe COVID-19. And also the study found that people 65 and older experience a rapid decline in the immunity against COVID-19, regardless of what the vaccine they had received. And also the researcher emphasized that a number of variables, including the type of vaccine, vaccine age, patient age, and newly developing variation, and geographic location, all this could affect overall efficacy. And so our recommendation is the future research must investigate how well Omicron and newer variant work to prevent hospitalization. And finally, according to the study, vaccination were 90% effective for up to 6 months against severe COVID-19. And thank you for listening. I make it so concise because of the time. Thank you so much.
Thank you, Dr. Shara. I mean, you will finish it before the time that we've actually
Yeah,
said.
I just made it for
So you did it good. You did good.
Yeah.
Thank you. And our next topic is the effect of COVID-19 as a whole on heart. Will be presented by Dr. Naveen and Dua. They're going to split the topic between them and going to present. So whoever is going to present, go ahead.
I think I don't know how to stop the share.
Yes. Can you please unshare?
Yeah, I'm not sure.
Just exit your PowerPoint and click on the webinar. Click on the Zoom meeting, and you'll have click on the share content. Then you could exit. Yeah.
Okay.
No. You're still in the PowerPoint, right? Yeah. Exit the PowerPoint.
Okay.
And click on the Zoom meeting.
Share.
That's like the how do I say? The one right to your PowerPoint in the.
I'm so sorry.
At the bottom of the screen.
Yeah, the bottom of the screen, right next to your PowerPoint.
I think you did it from Google, so you can just click this Firefox, right? Or it's here, okay.
No, I'm not sure.
Yeah, just click the same thing. The one that you click. I think that's the right one. Yeah.
Stop share, yes, okay. I'm sorry.
Yeah, no problem.
So good afternoon, everyone. Can you see my screen?
Yes.
Yes, we can.
Okay.
Noreen, can you please click this down? Yes, it's good.
Okay.
Thank you.
I'm sorry. So can you see my screen? Actually, is it okay?
Yes.
Okay. Thank you, everyone. And my name is Noreen Saeed, and me and my colleagues Dua Muhammad and Rawan Rashid and helped in preparing these slides on the topic of effects of COVID-19 on the heart. I will be discussing about the basics of the COVID-19 effects on the heart, and Dr. Dua will be telling more about the cardiac manifestation. So although the COVID-19 is primarily as a respiratory and the lung disease, it can also affect the heart, and the temporary or the lasting damage to the heart tissues can be due to several factors. So the clinical manifestation may be presented as an asymptomatic, or it can be symptomatic. And the asymptomatic, they may have no symptoms of the heart disease, but have cardiac test abnormalities such as the serum cardiac troponin elevation, the ECG abnormalities, or the cardiac imaging findings. The symptomatic may be having the cardiac symptoms, including palpitation, chest pain, and dyspnea. The cardiac manifestations can include, the COVID-19 can lead to heart problems among people who never had any heart issues earlier. And they are much more prone among the hospitalized and the critically ill patients. The the patients who were admitted to the hospital for COVID-19 had a 20 to 35% incidence of myocardial injury manifested by an increase in troponin. Heart failure in patients with COVID-19 may be precipitated by acute illness in patients with pre-existing heart diseases manifested by elevated natriuretic peptides. Cardiogenic shock, cardiac arrhythmias have also been reported in COVID-19 patients. So the cardiac testing that are done includes the biomarkers, EKGs, echocardiogram, and cardiovascular magnetic resonance. And the biomarkers are usually included the cardiac troponin and the natriuretic peptides, which are mostly elevated. The EKG findings are the atrial fibrillations or the flutter, right bundle branch block. The echocardiogram on the transthoracic echocardiography shows the right ventricular dilatation and dysfunction, the left ventricular diastolic dysfunction, and the left ventricular systolic dysfunction. And the cardiovascular magnetic resonance abnormalities have also identified in patients with COVID-19, as well as in patients who have recently recovered from COVID-19. So the pathogenesis of cardiac injury in COVID-19 is pretty complex, and the mechanisms that includes are usually viral mediated injuries, microvascular dysfunction, thrombosis, cytokines, and type 2 myocardial infarction. The histological features seen on autopsy includes increased macrophages and cytokines elevation. The cause of injury is likely multifactorial with evidence of inflammation as manifested by macrophage infiltration, and less commonly a typical lymphocytic myocarditis. Other clues, as the virus causes inflammation fluid to fill up the air sacs in the lungs, less oxygen can reach the bloodstream. The heart has to work more harder to pump the blood, and which can be dangerous in people with pre-existing heart disease. The heart can fail from overwork, or insufficient oxygen can cause cell death and tissue damage in the heart and other organs. And now Dr. Dua will continue.
So, hello. We'll continue on the manifestation of effect of COVID-19 on the heart. Since it's a viral infection, so most of the viral infection cause myocarditis, which is inflammation of the heart. So the coronavirus can infect the heart either directly or indirectly. Directly by damage the heart muscle tissue, or indirectly by body's own immune response. And also another theory that due to virus, so the heart-like inflammation can affect the inner surface of the vein and artery, so can damage the vessels and lead to compromised blood flow to the heart and other part of the body. The other manifestation is stress cardiomyopathy. Since it's a viral infection, so the body reacts as stress and release surge of chemicals like catecholamines, which can affect the heart and do like cardiac stunning. And when the stressor resolve, then this will be from the maybe temporarily manifestations, so the heart can recover. So it is a cardiac stress cardiomyopathy, and it's usually a dilated type. So the heart had like difficulty pump the blood. Then also we can go for the arrhythmias effect and conduction system. So patient with COVID may be at increased risk of certain arrhythmias, and those factors it can be such like severity of the illness or is specific to some medications. So the vast majority, there is no symptoms of arrhythmia. The vast majority of patients presenting with systemic illness consistent with COVID-19 will not have symptoms or sign of arrhythmias. or even conduction system. But maybe some patient can present with the tachycardia, so it may not be related to COVID itself. It can be related to the illness related symptoms like like fever, like pain, or shortness of breath. So it may be like misdiagnosed as arrhythmias or okay. So also another theory may be like a complication from more severe infection and mechanical ventilation. Those can be predisposed to atrial fibrillation or other atrial arrhythmia, and the presence of hypoxia, shocks, or evidence of widespread systemic inflammation. Those all can end it with arrhythmias. And also, if there is any electrolyte disturbance, they can develop arrhythmias as well. So all this is can be like symptoms related illness, not like COVID itself. Okay, but it will put it in mind. Then the others following observation has been reported from various cohorts like QT prolongation, atrial fibrillation, out of hospital cardiac arrest, in hospital cardiac arrest, ventricular ectopy or tachycardia, and bradyarrhythmias. So some new we check some news effect on the heart. It's a release on August this year that there is reduced myocardial blood flow. This is like new clue on how COVID-19 is impact the heart. So we'll give you a summary and you can read more about it. We already provide link for that. So they think that patient with better COVID may be like more twice as likely to have unhealthy endothelial cell uh, that line the inside of the heart and blood vessels. So, according to newly published research from Houston Methodist, this finding offer new clue in understanding COVID-19 impact on cardiovascular health. And they found that like 20% decrease in ability of coronary artery to dilate. So this condition known as microvascular dysfunction, and its dysfunction and inflammation of endothelial cell is a well-known sign of acute COVID-19 infection, but little is known about the long-term effect of the heart and vascular systems. So earlier in the pandemic, they think that myocarditis is one of the most common uh, cardiac manifestation, but recently they said this is like a rare effect of viral infection. And the recommendation, further studies needed to document the magnitude of microvascular dysfunction and to identify strategies that will be appropriate for early diagnosis and management. So, in general, for instance, reduce myocardial flow reserve. This can be used to determine patient risk when present with symptom of coronary artery disease over or above the established risk factors. So, which can be quite relevant in dealing with long COVID. So, this is like if you have a patient without really like risk factors, let's say younger, no risk factors, no associated condition, and he got COVID. So we can think of COVID if he present with coronary artery disease. Okay, and I think that's all. If you have any comment or question, you can just write it at the end. You can just ask me. Thank you, and that's all. I just
Thank
attached
you
the.
so much.
You're welcome.
Yeah, thank you so much, Dr. Noreen and Dr. Dua for giving us a very good insight about the effect of COVID-19 on heart as a whole. So our next topic of presentation would be the efficacy of COVID-19 vaccine in heart transplant and heart failure patients. It has to be presented by Dr. Humaira, but unfortunately, she is not able to attend the meeting because she's stuck in the traffic. So I do have her slides. If Dr. Nadir, do you want me to present on her behalf, or would it be a good idea if she will present it to you later on, or whichever way is good for you?
I think we can cooperate. If you can go last question, see if you have slides, and then I can talk about later.
Okay, so Sorry, I couldn't hear you. So do you want me to
Yes.
present it right
Can
now?
you present? Can you present it?
Yeah. Sure. I
Thank you.
can.
Thanks.
Let me share my screen. Okay, so the next topic is efficacy of COVID-19 vaccine in heart transplant and heart failure patients. The slides were prepared by Dr. Asma and Dr. Humaira. Going to our topic of presentation, COVID-19 vaccination in heart failure patients. The reason why we are talking about, especially about heart failure and heart transplant patients, is because like earlier, what Dr. Dua and Dr. Noreen has presented about the effects of COVID-19 on the heart. These patients of the patients of heart failure and heart transplant are immunocompromised, are in a state of immunocompromise. So they need additional. So the efficacy that we see in the regular patients is different compared to these patients. So the clear benefits regarding prevention of symptomatic SARS-CoV infection and related serious non-fatal and fatal complications always outweigh the risk of side effects, which are generally mild and short-lived. And neither heart failure nor common cardiovascular, not cardiovascular comorbidity is considered the contraindications for the preventive procedure. There is no evidence on comparative efficacy or safety of the available COVID-19 vaccines among the patients with heart failure. Optimally, the patients with heart failure should be vaccinated against COVID-19 vaccine in a stable clinical condition, and no reported interactions between any approved vaccine and medications administered in patients with heart failure. The diagnosis of heart failure, particularly when present in an elderly or in a frail subject, is a strong predictor of non-lethal and lethal complications of COVID-19, which include a need for intensive non-invasive and invasive respiratory support, and pharmacological and mechanical circulatory support as well, and would also lead to a longer hospital stay, especially in the intensive care unit, and the prone to pneumonia, severe pneumonias, and respiratory failure compared to the normal individuals. And they're also prone to thromboembolic events and secondary myocardial damage, like mentioned, coronary artery disease, and circulatory decompensation and neurological complications as well. All COVID-19 vaccine trials have recruited cohorts of subjects, including those with coronary vascular disease and heart failure, and have confirmed the vaccines to be safe and effective in these groups. The rare cases of thromboembolism and myocarditis need to be acknowledged, but also confronted with overwhelming survival benefits due to COVID-19 vaccination seen globally. COVID-19 vaccination is indicated for all heart failure unless other contraindication exists. As mentioned, all the heart failure patients with a compromised immune system, including patients following a heart transplantation, receiving the immunosuppressive therapy, need to be vaccinated and are unlikely to generate a completely protective immune response after COVID-19 vaccine. And therefore, they need additional preventive measures for sure, even after they receive the vaccine. And they also need an additional dose of COVID vaccine to increase the efficacy. And it is suggested not to administer the vaccine to individuals with a known history of severe allergic reactions, like mentioned earlier, when we discuss about the side effects of COVID vaccines and contraindications. And however, it should not be considered as an absolute contraindication, especially in case of a patient with immunocompromised, who's immunocompromised. Intramuscular injection required for COVID-19 vaccination can cause hematomas in patients with platelet defects. And the benefit of COVID-19 vaccine is expected to be greater than the risk of local bleeding. Therapy with anticoagulants or antiplatelets in patients with heart failure is not a contraindication for vaccination against COVID-19. All approved COVID-19 vaccines must be applied intramuscularly and subcutaneously, and subcutaneous injections are not allowed. COVID-19 vaccination is indicated for all frail patients with heart failure unless other contraindication exist, like mentioned earlier. And a structural follow-up of vaccinated patients with heart failure is preferred for a long-term follow-up of the patients. And but necessarily there is no need of assessing the COVID-19 antibodies in that particular individual. And the knowledge and strategies preventing COVID-19 infection forms an important part of comprehensive education programs delivered to heart failure patients. Heart transplant recipients have demonstrated a weaker immune response to the vaccination against COVID-19 compared to the general population, especially the older age, and also because of the immunosuppressive drugs we use to prevent the transplant rejection. And the vaccination during the first year following the heart transplant have been indicated as a potential determinant of a poor immune response. A study done during in December 2021 has showed, which included a total of 563 heart transplant recipients with an average age of 60 years, who received at least one dose of COVID vaccine. And out of the studies with a reported gender distribution, 64% were male and 35% were female. Likewise, the patient population enrolled in the studies were from different parts of the world, like Israel, Europe, Taiwanese, and America as well. And the utilized vaccines for immunization of heart transplant recipients were Pfizer and Moderna and Johnson & Johnson, as well as AstraZeneca. So the immune response was measured after the second dose of an mRNA vaccine in 464 patients out of all, and after the third dose of a mRNA vaccine in 96 patients. So after the first dose of a mRNA vaccine in one patient, and after the single dose of vector-based vaccine in 2 patients, time to administration of the first dose of COVID-19 vaccination ranged from 8 days before to more than 166 months after heart transplant. And time from the last dose of the vaccine to the time of the last measurement of the immune studies included in the systematic review utilized a combination of humoral and cellular immunoassay in measuring the immune response against SARS-CoV vaccine against heart transplant patients. This included anti-receptor binding domain, anti-spike, and anti-nuclear capsid antibody levels, and neutralization or pseudo-neutralization activity of SARS-CoV-2 antibodies and immunogamma assay, and peripheral T cell counts or its subsets. Regardless of the laboratory test, immune response or the manufacturer provided cutoff for the detection of an immune response, a positive response was rarely observed in none to 100% of the heart transplant patients. Based on a qualitative appraisal of the included studies, a weaker immune response was implicated both with the American Society of Transplantation and ISHLT recommended vaccination of patients with heart failure and heart transplant recipients, and supported third dose for those who receive an mRNA vaccine. Although it is preferred that patients would complete the vaccine series 2 weeks or more prior to the transplantation, transplantation should not be routinely delayed. Updated recommendations suggest that transplant recipient should wait at least 1 month after transplant surgery to receive the COVID-19 vaccine. However, COVID-19 vaccine should be postponed for at least 3 months following T cell or B cell depleting therapies, like when we are using the immunosuppressive therapy. And whenever, or as a treatment that we use as a treatment for rejection. And there's also an observational study done which established that the COVID-19 vaccine is effective at reducing symptomatic disease, hospitalization, and death from COVID-19. And the summary, the immunological response to the vaccine is probably somewhat more complex than measuring antibody titer, as a T cellular response and studies with longer clinical follow-up are. And here are some of the links which will give you a more detailed explanation about the efficacy of the COVID vaccine in heart transplant and heart failure patients. Thank you. And now I'm going to present my topic, which is measures to increase the efficacy as a whole and also in heart failure and heart transplant patients. So the question is, after you guys have listened to every single topic that we've presented so far, so do we need to postpone our heart transplant or LVAD placement in heart failure patients? I think we can answer about this question after we go through a few slides. There are many factors affecting the efficacy of COVID vaccine. There could be external factors or internal factors, and the external factors could be the type of vaccine or the immunocompetency of the host and the timeline when the vaccine is being administered. And the internal factors would be while manufacturing the product, like during the manufacturing and during the transportation, and also with the storage of the vaccine vials, and also with the different kinds of drug interactions that we have. So each of these points will be addressed. And as already mentioned, different kinds of vaccines, like the type of COVID vaccines. So all of them are, none of the COVID vaccines are live vaccines. So all the vaccines definitely need a booster, whether it be in a general population or in immunocompromised patients. And the booster vaccine can be a homologous or a heterologous booster vaccine, because these studies have done and which have shown that heterologous vaccination regimens have provided higher induction of immunogenicity and tolerated reactogenicity in the patients. And all the patients would be immunogenic at least within 12 weeks of the vaccination regimen. And coming to the methods to increase the vaccine efficacy during manufacturing, which is one of the factors that plays a role, the benefits of the delivery platforms, which is a newer outcome targeting the vaccine delivery and the efficacy, plays a very important role to increase the efficacy of the vaccine, which concentrates on the physicochemical properties of the vaccine formulations, especially during the long-term storage and transportation, should also be optimized for rapid development and mass vaccination across the globe. And the interventions improving the efficacy of COVID-19 vaccine in patients with heart failure would be the vaccination against COVID-19 in patients with heart failure is needed as early as possible, preferably in a clinical optimal state, and optimized treatment of heart failure and other comorbidities as well. However, the treatment optimization should not delay the COVID-19 vaccine. And as we all know, most of the heart failure patients might be having an associated anemia. So the iron repletion prior to COVID-19 vaccine has potential to optimize the vaccine benefits in anemic patients with heart failure. And the preventive measures, including the use of face mask and hand disinfection and social distancing, are still needed in spite of getting a COVID vaccination in case of heart failure and heart transplantations. The various needs and modes of monitoring the efficacy of COVID-19 vaccination in patients with heart failure would be a structured clinical follow-up, and the need for increasing the awareness and education on COVID-19 vaccine in patients with heart failure is very much needed, because the knowledge and the strategies of preventing SARS-CoV infection forms an important part of comprehensive education programs delivered to patients with heart failure during their regular follow-up, clinical follow-up. And why and when are the additional doses required? So as it is already mentioned, the immunocompromised patients, whether it be the heart transplant patients or the heart failure patients or any other patients who have an immunocompromised state, does not generally generate a complete protective immune response after the COVID-19 vaccinations. So these are the potential candidates who need an additional dose. And also, the additional dose of vaccine beyond the standard scheme may increase the efficacy of vaccine in these patients. Like usually, the time line where we give the booster dose would be around after 3 months for a regular population. But maybe for these immunocompromised individuals, that timeline can be, cut short to 6 weeks, such that they would achieve the efficacy needed. And like we said, like already mentioned, the drug interactions, could the drug interactions affect the COVID-19 vaccine? Frankly, the studies done so far does not support the fact that the steroid injections given for the treatment of epidural, for the treatment of back pain or any other problems does not affect the efficacy of the COVID vaccine. And the physician should consider timing of an elective corticosteroid injection such that it is administered no less than 2 weeks prior to COVID-19 vaccine dose and no less than 1 week following a COVID-19 mRNA vaccine dose, such that the patient would achieve the maximum efficacy of the vaccine that he has received. And it is observed that vitamin D has played as an adjuvant in the vaccination protocol in COVID-19. It is because the vitamin D has helped to reduce the pro-inflammatory cytokines, which has helped to increase the amount of antibody protection, such that the patient could have the antibodies protecting them for a greater amount of time, and which has increased the efficacy of the COVID-19 vaccines. So the conclusion would be a global preventive strategy, including vaccines and pre-exposure prophylaxis with monoclonal antibodies and early administration of vaccines and booster doses in immunocompromised patients is a must. And a recent study done using the treatment with Evusheld has shown that we could reduce the rate of infections and severe illness among the immunocompromised patients. So these are monoclonal antibodies, which are given to, especially to the heart failure and heart transplant patients before they undergo the procedures like LVAD placement or a heart transplantation to improve the efficacy of COVID-19 vaccine. So yeah, thank you. These are all the references that we have had.
So thank you so much, everyone. These are the whole slides, right? Or I'll be missing some.
Sorry, Dr. Nader?
It is all and all.
Yeah,
all,
yeah,
right?
yeah.
Excellent. Just don't wanna miss any. But I think all in all, you did a great job, every one of you, presented the whole important information about the subtopic. So I think it's excellent presentation, excellent effort and work. What's the time that you think we should advertise? Because with the time now, we presented about 1 hour and 12 minutes. Do we need to do the same and then leave some time for questions?
Yeah, my actual plan was, we actually thought of finishing it off within 45 minutes to 1 hour, and maybe extend for another 15 minutes for the discussion at the end. by the cardiologist in case, anybody comes up with any questions and all that. During today's presentation, we had some technical issues, so maybe that would be the reason why we had another 10, 12 minutes extra. So I think everybody have done a very good part, and we could definitely finish in 1 hour, and we can add an extra 15 minutes for the discussion.
Perfect.
So it would be 1 hour, 15 minutes.
Okay. Or you can shoot for 1 hour and 1.5 hours, as you mentioned, depending on the audience and the question. If we finish early, that's fine. We have time for more questions. But the topic itself is very important, and I think we covered very important areas. So back to the feedback. So all in all, you did great. The material itself is very good. The slides, most of you did a good job. What we need to do is we need to work on finalizing the slide, the part of the slide. So one suggestion is to make the slide as simple as possible. And in your speaker note, you can add whatever you want to say, so that the slides might not as busy and you're not reading whatever written in the slide. The way they do it is when you finish the slides, if you put it in a PDF file, people can look at it, but they need additional information. This is why it's your own work, unless they come to the webinar, the video, the recording, they will not get the whole idea. So you need to make it simple in the slide, and you can add your wording, your text as a speaker note instead of giving us busy slides. That's number one. Number two, sometimes when you present, we may read slowly, and then the audience might be a fast reader. So if you have a busy slide, they can read faster than you, and by the time you reach half the slide, they will be like waiting for you to finish. Basically, it will not be as engaging or as interesting for the audience. This is what we think as far as presentations are the slides. We can go over the slides. I can help you guys. Each one, we can share the slides and we can go over what we can do about that. Time is very good as far as each one of you. What I suggest, the earlier the topic about the background and some of the history, maybe we can reduce that a little bit, because I think it's by now more than that in the pandemic. People know a lot, but they don't know more about the heart and the technical part about the heart failure. And so we can focus more on the subject of the topic, like the vaccine effect, side effects, and the heart, and then endocarditis, and that more. And I think you said we will have some cardiologists at the end. Maybe they can shed some light more with their comment there as well. But all in all, I think you did great. As you said, we have some technical time spent, so we can solve that when we have all the slides ready. We can combine them, and then when the moderator will have all these slides ready, and then all the files ready. So in case the presenter has technical issues, we have them on the back. I don't think I have many job, good presentation, good skills as far as the way you handle all the material. And I think it's important topic. So thank you so much, everyone. Any specific question from any one of you want me to address certain part of your presentation?
Yes, Dr. Nader. Assalamu alaikum.
Alaikum salam. Go ahead.
Yes, you said you have to make the size smaller or make the slides more to arrange it like to be easier and to be specific and to be short, right? So
Yes.
I saw that in the app, the slides going like summarized, and then in the bottom there is some explanation or down. How to do that? I'm not sure.
So there are ways to do that presentation. One of them, PowerPoint has, when you have the, I can share with you just a second. So if I want to share with you my screen here, either PowerPoint or, for instance, Google Slides. If you write slides.io, it will bring you a new presentation. Here, the main slide, you have it. This is where you put your data in the slide. At the bottom, there is the speaker notes. This is where you will add the full sentence. For example, you will say item number 1. So here you will speak about item number 1 in more details. So in your slide, it might be bulleted items, if that makes sense for you. So here, item number 1, item number 2, item number 3. So, for example, I'm gonna say today I'm gonna talk about the most common side effects of this vaccine. Number 1 is, let's say, GI symptoms. So one of the most common GI symptoms is nausea, vomiting. Although this is very common, some other symptoms, including diarrhea or whatever, are recorded or mentioned in the literature. So you don't have to put the whole sentence here. Because if you put the whole sentence here, it will be a very busy slide. Number 1, for a slow reader, you'll go one sentence at a time. If you are a fast presenter who read fast, they will be at the end or at top item number 3, while they are reading item number 1 because they couldn't finish the whole sentence.
Okay, get you. Okay. Thank you so much, Dr. Nader.
You're welcome.
Appreciate it. Thank you.
Good question. Excellent. Any other questions? So if you look at some of the slides, like the one is done by GRS, sometimes you can see that if you open the file, you will have some of the slides are limited, but if you look at the speaker note, they explain more detailed information.
Yes, I saw that in the bottom, yes.
Yes, at the bottom.
Okay, perfect. Thank you so much.
You're welcome. And one of you, I think, in the presentation, they presented on a speaker mode. I'm not sure. So presenter mode, I'm going to show you again. So if you use PowerPoint or maybe you use Google Slide, when you click, there is an option of presenter view or presenter for speaker mode, where the slides will be. I'm not sure if you can see that. I'm going to stop and share again. The slide will be here, this is where the viewers will look at, and for you, it will be here. So remember on the slides on the PowerPoint when you're preparing, your notes are at the bottom of the slide, right? In the speaker note or speaker mode or presenter mode, your notes or the full sentence, full text will be here, but it will be presented, the slide on this box, and I can do that for you guys just in a second. So I'll share the screen and I can limit. I can limit the area. So now you are seeing only my 3 items. Is that correct?
Yes.
You're not seeing my text. If I increase if I move this, then you can see my text, right?
Yes.
Yeah.
So basically, this is where the slide will go. So as you move the slides from one slide to the next, this is what the audience will see. But for you, as a speaker or presenter, you can see both of them. You can see the slides that other people watching, and you can look at your notes, and you can read them or you can refer to them. If that makes sense for you. Any other questions?
Okay, thank you so much for the feedback, Dr. Nader. Well, I do have questions regarding when would be a good time and date for our webinar to be hosted.
So I know you are going through the process for the RAP and application interviews. And
Yeah.
so, so which days, which dates for you might be good? For me, I think a weekend might be a better, Sunday might be a better timing, maybe between any time between 1 a.m. to a.m. until 6 p.m. Any window, and you can decide 1.5 hours or something like that. Depending on your availability and depending on the other specialists like the cardiologist availability at that time. Because you think about the time for other overseas, like people in Africa and like, I'm not sure time difference there, but at least in Europe they can watch before midnight for them.
Okay. We are planning to do it by next week. So since you said that weekends are going to be a perfect time, do you think the next Sunday would be a good time to host a webinar? Not the coming Sunday, because it's a very short span, I suppose. I mean, if everybody agrees, I'm okay with that. Like, we can just work on it and finish it off. Work on just we need to make a few changes in the slides, like you mentioned, kind of precise. The slide should be precise, where the conversation should have to flow, like you mentioned. We can work on it. And like most of the people have done a very good job with the slides as well.
Sure,
so I think just 2 or 3 people have to work on the slides. Yeah. So if you think this Sunday would be a good thing, we can go ahead. Already the flyer is ready. I'm just waiting for your approval to include the date and time. I just want to confirm it with you. Sure. And obviously the time period for the webinar as well. So since we fixed it, would be a 1.5 hour. The time period would be 1.5 hour.
I think we can do it somewhere. That's fine. But we
Okay.
need to, yeah, as you said, work out in getting everything. And I think maybe on Saturday after we meet, we can have maybe 15 minutes, 20 minutes, half an hour to just run the technical part as far as who will be present, moderator, and the rest, and how to introduce, how to
Yeah.
open the files, the slides, to will move them, something like that. So by the time we are Sunday comes, we are ready just to go ahead. We don't have to.
Yeah.
Exactly.
Yeah, that sounds perfect. Yeah, it sounds like a good plan. And my other concern is regarding the flyer. I will forward you the flyer, and please provide your suggestions. What else? What kind of changes it would need? I'm coming up with two kind of ideas, so I'm going to forward both of them to you. And likewise, like I already mentioned, regarding our collaboration with the IMG project team, which would give us a big platform to reach a wider range of audience. I'll talk to them and get back to you as soon as possible, such that since we're planning to host the webinar this Sunday, yeah, I just want to get things done as soon as possible. And really thank you for your time and consideration. And I really want to thank every member of the team to participate, and you all have done a very good job. Thank you all so much for your support.
Thank you. Thank you. Yeah.
In case
Thank you,
anybody has
everyone.
any questions and doubts, please reach out to us, and we'll work together and do a very good job.
I think everyone did a great one. Great
Yeah.
job, and the effort is awesome. And I think it's going to be beneficial for the audience. So one thing I need to ask everyone is to prepare your photo, professional photo, and then we can work on the flyer. And then the flyer, we need to identify how we want to distribute that. And so you can think about which group is it, what group is it, Facebook, is it on Twitter, whichever you decide, so that we can work on it. So.
Okay, Dr. Nader.
Thank you, Dr. Nader.
Thank you so much, Dr. Nader.
Thank you, everyone.
Thank you, Dr. Nader.
Thank you so much.
Have a good day.
Bye.